Hello, everyone. Welcome to the second day of breakout sessions of the virtual Iowa Governor's Conference on Public Health. As you know, we usually are able to meet in person yearly to share our best practices and lessons learned, but like with everyone else, coronavirus has caused us to pivot, but not to forgo our commitment to learning and growing. We're very excited that you've decided to spend time with us today, learning from our own public health experts around the state. My name is Elizabeth Faber, and I'm a consultant with the Iowa Public Health Association. I'm facilitating both the Iowa Immunizes Coalition and the Public Health Workforce Development Task Force. I'm grateful you've joined us today over your lunch hour and hope you will continue to meet with us daily to support our public health colleagues as they present your work to you. So the Governor's Conference is put on every year by Iowa Public Health Association and Iowa Environmental Association. I encourage you to join their public health associations, join your colleagues as a member of Iowa Public Health Association. So our mission is to unite and strengthen the voice for public health in Iowa, which is exactly what we are doing today. Go ahead and make sure I'm sharing with you our correct PowerPoint. So hopefully that is correct. Normally Lena is doing this, as you know, if you participated before, and she's unable to be here today. So I also want to thank the sponsors and exhibitors of the virtual Governor's Conference. Their commitment to public health is paramount, especially in these times. The sponsors of the virtual conference are Aetna, Amerigroup, Unity Point Health, and the University of Iowa College of Public Health. You can also find a list of all of the virtual exhibitors on our Governor's Conference website at iowapha.org. So before I introduce today's speakers, just a reminder that everyone is on mute, and to ward off any Zoom bombers, the chat function is set to allow you to communicate only with me. So at the end of each presentation, there will be time for questions. So you can use the chat button or the Q&A button at the bottom of your screen to ask a question. And I will then read those questions to the presenters. So today's first presenter is Olivia Masterson. She will be discussing a probiotic intervention used to prevent C. diff infection, a bacteria that causes life-threatening diarrhea. So Olivia, I will hand it over to you.
All right. Hopefully I got this working. All right, so looks like it's working today. So kind of to start things off, as mentioned, my name is Olivia Masterson, and I'm currently a senior at Drake University. So through my senior year at Drake University, I had the opportunity to work at an internship site at Broadlawns Medical Center in Des Moines, Iowa. So working with my preceptor, Dr. Indermeeser, we came up with this capstone project of looking at probiotic intervention that Broadlawns had in place to prevent C. diff infections for high-risk patients. All right, so kind of to start off with, what exactly is C. diff? As I'm sure many of you are already aware, C. diff is a bacterium that causes diarrhea and colitis, which is an inflammation of the colon. So kind of to go off of that, what are some symptoms of C. diff? The CDC states that symptoms can range from fever, stomach tenderness or pain, a loss of appetite, diarrhea. And so with this diarrhea, it's going to be a loose, watery stool, and bowel movements are going to be more frequent compared to normal bowel movements and stools. And so some of the risk factors for a C. diff infection, being 65 or older, a recent hospitalization, a weakened immune system, and or a previous C. diff infection or exposure. So kind of some of the issues that we're seeing with C. diff right now, the CDC is approximating around 500,000 illnesses to the C. diff bacterium annually. And so kind of some aspects we're seeing with infections. Historically, C. diff infections have had an association with healthcare facilities. So meaning that a patient who has a C. diff infection will have had an infection that was from a healthcare facility. So kind of a stat with that, after 1 month of diagnosis, 1 in 11 patients over 65 will die of a healthcare associated C. diff infection. And so another thing with C. diff infections usually occur after an antibiotic usage. And so meaning a patient will finish an antibiotic dosage for any given thing. And then so after that, with kind of what we're seeing now with the antibiotic usage and cases in general, cases are becoming more atypical and the strains are becoming more aggressive since the year 2000. So when we say atypical cases, meaning younger, healthier patients who don't really follow within the normal risk factors that we're seeing. And then the aggressive strains are just more strains that are more resistant towards treatment. And then lastly, C. diff infections can be reoccurrent, meaning that another infection can occur after that initial episode. And so again, another stat from the CDC, about 1 in 6 patients who will get C. diff will get it again after a subsequent 2 to 8 weeks after their first diagnosis. And so kind of what measures can be taken to kind of try to prevent a C. diff infection? The CDC has labeled C. diff as an urgent threat within a 2019 report on antibiotic resistance. Within that same report, in 2017, we had about over 200,000 cases, and they were costing in total healthcare expenditures about $1 billion. And another finding with that also, C. diff cases acquired from healthcare facilities were decreasing while we were seeing an increase within community-acquired cases. So community-acquired meaning outside of the hospital and not within inpatient settings. And so one kind of preventative measure that has been kind of debated within research is this aspect of probiotics. So in theory, probiotics would help to restore normal gut microbiomes that are disrupted from antibiotic usage and a C. diff infection. And so kind of within the literature, we're seeing mixed results with the effectiveness of probiotics as an intervention. Current national guidelines are saying we shouldn't be recommending usage of probiotics as a routine just because of studies' mixed results and the vastly variable methods that we're seeing right now. Specifically, within one study from the BMJ, in 2007, they found a significant reduction in their C. diff and AAD, or antibiotic-associated diarrhea, rates using a probiotic supplement, Actimel. And this product contained the probiotic species of Lactobacillus casei, Albogaricus, and Staphylococcus symphylis. And so kind of based on this study, Broadlawn's implemented an inpatient probiotic supplement intervention using a similar product to the one found in the BMJ, Dan Active, which is a Dannon probiotic product. And this supplement contained the species Lactobacillus casei immunatus. And this started for high-risk patients within 2019. And so kind of the goal with this protocol was to prescribe it twice daily for patients with high risk factors. And after their discharge, they were continued to be encouraged to use it at minimum 1 week or up to 4 weeks after their discharge. And so kind of some of the methods we use to analyze this protocol, we set up a quasi-experimental study to look at the effectiveness of the inpatient probiotic intervention with an intent to see if this protocol reduced CDI laboratory orders and other related testing. And so kind of to go off of that, our prophylaxis was based on risk factors from that probiotic protocol. Some of the risk factors that are outlined within the BMC protocol is antibiotic usage of one or more of the following. So antibiotics of clindamycin, cephalosporins, fluoroquinolones, amoxicillin plus colanonate, and ampicillin sulbactam. Another risk factor would be age greater than 50 years old. And then the last one, and or a history of AAD or CDI. So again, antibiotic-associated diarrhea or a previous C. diff infection. And so within our study, we categorized our data into 4 quarters with 1 year prior and after implementation. So our pre-intervention started within September of 2017, and within these quarters, they were in 3-month intervals. And so our pre-intervention stopped within August of 2018. and our post-intervention started September of 2018 and went until August of 2019. Another aspect within our methods, we kind of set inclusion and exclusion criteria. The inclusion criteria are criteria for our qualified cases involved an inpatient CDI diagnosis and a previous exposure to broad lungs within 90 days of that diagnosis. And then lastly, our outcomes. Our primary outcome was a reduced inpatient rates with the probiotic usage, and then secondary revolved around reduced laboratory orders for CDI and other applicable testing for these infections. And so kind of the data analysis of our study involved a caseload of 20. And within these 20 cases, we utilized a Qualtrics survey with questions based on our inclusion and exclusion criteria. Some of the baseline variables that were collected with this survey involved antimicrobial days of therapy, PPI H2 blocker usage, antibiotic type, diagnosis, location, applicable readmission statuses, mean were these patients being readmitted to the hospital after an infection, protocol-based contraindications. These contraindications would affect a patient's ability to receive the Dan-active probiotic supplement, status of the inpatient probiotic orders, and then the age and gender of these cases as well. And so initially when looking at kind of some designs for the study, we initially wanted to use an interrupted time series or an ITS design, but we were unable to do this just because of our low caseload of 20. Baseline requirements for these types of studies are usually around 100. So obviously with that, we couldn't really do that effectively with that study design. However, we were able to use a Mann-Whitney test to compare our total qualified cases per 1,000 patient days between our pre and post intervention groups. And so kind of what we found within this study, this first graph kind of ties back to our primary outcome of looking at CDI caseload between our pre and post intervention group. And so kind of what we found within this primary outcome is 36.4% of our total cases qualified based on our inclusion criteria in the pre-intervention group, and around 32.9% of total cases qualified based on our inclusion group within the post-intervention group. And so kind of our Mann-Whitney U result test found that there was not a significant difference between pre and post intervention groups within the qualified. However, we did see a significant increase within our total lab identified cases between pre and post intervention. And so our secondary outcome, we're kind of looking towards the laboratory orders. This graph kind of illustrates between pre and post intervention what we're seeing within the laboratory testing, that the laboratory testing being PCRs, toxins, and GI panels. So as you can see, there's a huge surge within the GI panels, and this may be due to the increased knowledge and availability and usage of these tests among providers. And in general too, there was an increase in the CDI cases. So with that, you're gonna have an increase of your orders with an increase in cases. And so lastly, this is kind of some of the characteristics we had seen within these 20 cases. Obviously, as stated before, there was more variables collected, but this kind of breaks it down as to where they were diagnosed between inpatient or outpatient, whether or not they had previous institutional exposure to broad lungs, and then additional cases after their initial diagnosis. And so kind of with this, we saw that outpatient diagnosis was greater between pre and post intervention compared to inpatient diagnosis, and additional cases of CDI decreased between pre and post intervention. So kind of a discussion of this study. Some of the limitations, obviously our low caseload kind of affected our ability to analyze the intervention. Utilizing an ITS would have been more beneficial. And another limitation we had was just the differences in the probiotic products, Actimel versus Dan-active. So Actimel was the one within the BNJ study. This product is a European product made by the French company Danone, which is the European version of Danone in the US. And then also within the two products, there was a difference between probiotic species. So the differences in species and products could have had a great effect within our results. Another limitation that we could have had was inadequate documentation by institutional staff. So kind of with this, we didn't exactly have enough documentation to kind of thoroughly analyze what we wanted to. And then lastly, just seeing an increase in the community cases may have attributed to our results towards probiotic effectiveness. And so kind of some of the implications of this study and kind of what we can take back from this is maybe this type of intervention isn't as effective at hospitals with pre-existing small C. diff cases like Broadlawn's. So with that, prior to this study, Broadlawn's had a low caseload of C. diff. So with that, it might be more effective at hospitals with a larger CDI caseload. And so again, suggestions for future research, utilizing an ITS design and with a larger caseload may allow for a better analysis towards the efficacy of the product. And kind of just to wrap things up, in conclusion, we looked at an institutional probiotic protocol that was in place at Broadlawn's, and it was analyzed for the efficacy towards the incidence of C. diff infections. We didn't really see any significant difference between the pre and post intervention groups. And then just for future research, utilizing an ITS design and increasing your caseload is going to be your best bet towards that. So with this last slide, if you use the QR code to the right there and scan it using the camera app on your phone, it'll take you to a Google form folder with a poster version of the slideshow, a PDF of the BMC probiotic protocol, and then also our data tables. So with that, that is all I have.
All right, thank you, Olivia. So attendees, please feel free to ask any questions that you may have, questions or comments for Olivia in her presentation. You can use the chat function or the question and answer. Olivia, I do have one question already in. Were the survey variables collected directly from participants, or were those data pulled from the medical records?
So they were pulled from the EMR. So we had set questions based on our inclusion and exclusion criteria onto a Qualtrics survey form, similar to like a Survey Monkey or sort of that sort of thing. And then using the EMR, we just collected using pre-existing data.
Okay, thank you. Please feel free to chat any additional questions, type those in. I did get one question asking about CEUs. There were CEUs for the other breakout session. This one in particular, these weren't. These were, we were not able to apply for CEUs for these because they were originally going to be poster sessions. So thank you very much to Olivia and Ed for agreeing to actually give these an actual oral presentation. So there's no CEUs for these, but there will be for the future virtual breakout sessions. And an additional question, Olivia, is wondering if you had said that one brand appeared to be more effective. Any comments on that?
So within the BMJ study, they did see a significant difference within the product Actimel. This is the European version product, but within our study we used Dan Active. We didn't see any significant difference within our qualified cases, but there's also highly variable methods and just kind of other factors within our two studies. So effectiveness, we can't really say one's better than the other, but within the Actimel study and the BMJ article, they did see a significant difference.
All right. Any additional questions? Let me see. Okay, one more. Does the facility plan to continue recommending probiotics for patients meeting the inclusion criteria?
As far as recommending it, it's still in place within the institution, and it's kind of a per patient kind of case thing. And so it's more along the lines of just preventing the infection rather than using it as a cure per se. But yes, it's still within the institution, and just within the study, we can't necessarily say of like, it is effective towards a reduction in C. diff incidence.
All right. I don't see any additional questions for you right now, Olivia, but if anyone does have any for Olivia, Olivia will be staying on so she can answer any after our next presentation. All right, I will hand that over to Dr. Bottei, and he's rightly concerned with potential contaminants in his beer. So I think this will be an additional good presentation to listen to at this time. So are you able to take controls, Ed?
Let's try it one more time.
Okay.
Yes, here we go. And
there you go. Perfect.
All right. So I'm Ed Bottei, the medical director of the Iowa Poison Center located in Sioux City. And I'm actually going to turn the presentation over to one of our nurse specialists, Susie Eades, who has been an ER nurse for 20-some, nearly 30-some years, and has been with us here at the Poison Center for about 7 to 8 years. I'm turning it over to her to give this talk because she was the one who picked up on what was going on with regard to lye in beer.
Good afternoon. My name is Susie, and I'll be doing this presentation today for you guys. And we titled this, "I'll Have No Lye with My Beer, Please." And we ended up with partnering with Public Health after noting an increase in beverage contamination with drink dispenser cleaners at commercial food establishments. Oops.
Yep. Right click, left click, left click.
Sorry. And we have no actual or potential conflicts of interest regarding this presentation. Use of trade names is not an endorsement of any product, service, or service.
Don't read the slides directly, just hide these.
Okay.
Again. Okay, just hit enter.
Okay. And this, of course, is a picture of seen in a lot of local establishments or across the Iowa and the U.S. in any type of food bar type situation. And the tap beer or draft beer is one of the main things that we kind of found that had issues with patients, with our callers, with exposure to the beer line cleaners or other types of cleaners that cleans the lines in establishments. And this is kind of the behind the scenes part where you have your kind of your draft tower at the top, and then it goes through the lines down into the cooler area of some type that holds the, like the keg beer, that type of thing. And then what we found is an unusual cluster of beer line cleaner exposures. We found this customers eating at various commercial food establishments prompted us to characterize our center's experience of beverage contamination with drink dispenser cleaners, whether it be at a restaurant, a convenience store, a bar, that type of thing. And then this prompted us with a call to us in January of 2019. Then we realized that we'd had an increase in these exposures here at our center. So we went into then the electronic medical records, and we searched from 2010 to 2019 for all cases involving ingestion of a cleaning product that was dispensed from a beverage machine of some type at any type of a commercial establishment. And this is a little graph on the certain types of alkaline beer line cleaners, and we did find that all of the the exposures that we had were an alkaline product, and some had quite high pH, which can be more problematic and cause more serious injury. And the products, some listed, they had either a sodium hydroxide or a potassium hydroxide in their cleaner. There were some that didn't list a pH, that just said that they were alkaline, and the normal pH is 7.35 to 7.45. So when you get up above 10, 12, that gets pretty alkaline and can cause some pretty significant injury with an ingestion. And then from there, with our results, we ended up with finding 27 cases over that time period. And we found the most to be from tap beer. So that's kind of how we came up with the no lie with my beer, please. 7 were from coffee dispensers. And out of that 7, there was 5 cases all at one coffee shop. Then we had iced tea, soda, and soft serve ice cream, a milkshake, and one was an unknown type product, beverage or food product. And then so we started out with having just a couple of cases in 2011, and then one in 2013, one in 2014, a little spike in 2017 to 8 cases, and then found 14 in 2018, which is quite a few. And then we have just the one in 2019 because that's when we started our evaluation to see what was all going on with this. And then out of that, we found location with the location of the customers. 10 were from beer line cleaners from like a bar or restaurant. 1 was a beer line cleaner from a golf course, so like a draft beer at a golf course. And then like I said, 5 were at a coffee shop. 3 exposures were at a convenience store. There were 7 exposures from a restaurant, and 1 was an unspecified business. And then out of those, then the cleaning products that we found there was specific beer line cleaners we found with 9 of our consumers, or our patients that we had. And they all had a pH pretty much greater than or equal to 13.5. 1 was a beer keg cleaner that wasn't specified. And then 1 type of the cleaning product was a sodium carbonate. 1 had a chlorinator pH of 10.4. And then we had 15 of our cases then were like an unknown or unspecified type of cleaner. And the comments were that it tasted like bleach, or it tasted like a cleaner or soap or perfume, that type of thing. And then the symptoms that we had, quite a range of symptoms, from mild to pretty serious. Everybody did develop symptoms of some type from their exposure. There was 8 that complained of a bad taste in the mouth. 5 had complaints of nausea. We had 4 with like oral irritation, throat irritation, sore throat, that type of thing. And then 10 had other types of symptoms ranging from burns to the lips, mouth, and oral pharynx. GI type symptoms were like vomiting, diarrhea, excessive oral secretions. Pain, of course, in the esophageal area, throat, chest, abdomen, and then some with some difficulty breathing or shortness of breath. And then we did find then out of our 27 cases, 13 people did seek medical care. We had 11 that went to an actual emergency department, and we had 2 that went to a clinic. And then out of these, then we had 9 that were treated and released from which facility they went to. We had 4 that were admitted to the hospital. Length of stay with those patients was anywhere from 2 to 4 days. 6 of the patients ended up having a scope, an EGD, and we did have 1 patient that was intubated with mechanical ventilation for their airway protection. And then we did have some significant EGD findings. One of the cases had the high pH of greater than 12, and this person had esophagus, upper stomach was scoped there, and they had severe burns and fibrinous exudate, and was in the hospital for 4 days. We had 2 cases that was with a pH of 14, and their findings was grade 2 burns and grade 3A burns to the stomach. And then, and their hospital days was, they were in the hospital for 3 days.
It's 1 patient per case.
Okay, all right. And then the third case we had, and this is the one that brought our attention, that piqued our interest with this situation. This one was a product that had a quite high pH as well, 13.5. The person was had a very difficult intubation, had lips were blistering already in the lips and the mouth. They had a swollen uvula, burns and edema down to the vocal cords. The esophagus had minimal damage, and the stomach had a little gastritis, but no necrosis, so which was very surprising for as bad of the exposure this person had. He was intubated in the hospital for 4 days, and then he was extubated on the second hospital day. And then also then just with some extra discussion of 5 of those cases that they began in late 2018 prompted our epidemiological investigation. The significant increase in cases starting in 2017, then it was reported to our state health department along with our epidemiological information. The state health department, partnering with other state agencies, sent a reminder to commercial food establishments about the importance of rinsing beverage dispensers after cleaning and the health consequences that can occur if they're not adequately rinsed. This is the alert that was sent out from the Poison Center and from the Iowa Department of Public Health that was sent to the establishments across the state to help them to be aware of, the dangers of this and to protect themselves, ways that, with using these cleaning products, because the people using the products can also have some serious symptoms from exposure, and then also then what to do if things like that happen, and to help prevent these tragedies as well. And in conclusion, while most of these exposures resulted in minor symptoms, serious injury has occurred. By partnering with public health, the Poison Center's findings led to an important reminder being sent to food establishments across the state. And does anyone have any questions for us or
All right,
or
thanks.
concerns?
Yeah, thanks, Ed and Susie. Appreciate that. If anyone has any questions, feel free to type those in the chat section or the Q&A. I'll go ahead and read those to Ed and Susie. Just a general question. Did you guys oh, I think I might have a question. So were the cases identified just in the Sioux City area, or was this from across the state?
The cases were from across the state of Iowa.
Oh, okay, all right.
Yeah, literally from one river to the next. So it spanned quite literally the entire state. And there was no one area in particular where there were more cases than others.
All right, let's see if we have any more questions coming up. Do you know what the long-term happened? Were the establishments sued?
Well, we don't know about whether or not the establishments were sued. The worst case that there was, the third one that was described where it was a difficult intubation, actually did quite well. And it turns out that all of these patients, fortunately, did quite well. There's not a lot reported in the literature about this phenomenon. And the one case I was able to find out about from another poison center, the person actually wound up having significant burns to the esophagus and esophageal strictures, but that did not happen in any of our cases. They all resolved well, fortunately.
Okay. Did the cases come from the beverage dispenser distributors cleaning the lines or from the owners trying to clean the lines themselves that you know of?
It was both. Most establishments will have the distributors do the cleaning, but that was not true in all of the cases that we handled.
Okay. Have you reached out to distributors to inquire about their tap cleaning procedures?
A little bit. We were mainly working through the state agencies to go down the pathway simply because there are so many establishments and so many distributors that we didn't know exactly where to start or what association or group to go to. And so it was through them that the information was passed on.
All right. And then another question was, do you know, did this prompt inspections of these establishments?
I know of one case in which the establishment was then inspected, but that wasn't a question we specifically asked or looked for. So it's possible that more were, but I only know specifically of one.
All right. Let me see if I can see if there's any more questions. I don't seem to see any. Just a reminder, a couple of you have asked, must have gotten on a little bit later, asked about CEUs, and for these particular presentations today, we don't have CEUs available because these were originally planned to be poster sessions, so we weren't approved for CEUs for these, but there will be CEUs available in our future breakout sessions. And yes, this will be available. These will be recorded and will be available later. You'll be getting information from IPHA about that. Let's see. Any other questions before we wrap it up? Okay. Well, thank you very much, Olivia and Ed and Susie. We appreciate you sharing with us, and thank you everyone else for your thought-provoking questions. Obviously, it's really interesting. We all definitely like to learn from our fellow Iowans, so appreciate being able to see all of the talent in our own state. Let's see, I need to switch our screen back over. Let's see if we can get that. So just a reminder that our next breakout sessions will be on Monday. You should be able to see the screen there. It should be the same links to be able to tune in to those breakout sessions. And every day at noon would it be the breakout and poster sessions that we would have had at our in-person conference. And be sure to check out the presentations. We will have them on the IPHA YouTube channel. So even though we are social distancing, we're still together, a network, and we are colleagues dedicated to public health in Iowa. So thanks again to our presenters. Thanks to all of our attendees. We appreciate you coming together, and you guys have a great day, a great weekend, and stay well.